Good evening, everyone, and welcome to the BASL Virtual School of Hepatology Series 2025. My name is Dr. Louisa Vine. I'm the BASL Education Lead, and my chair for this evening, or my co-chair, is Dr. Tamar Avaides, who's one of the BASL trainee reps for the Southwest. I'd like to thank our sponsors for the meeting. They have no influence or input into the programme, agenda or content of the meeting, so thank you to AstraZeneca, Advanced Pharma and Dr. Falk. So without further ado, I'd like to welcome Dr. Ryan Buchanan. He's one of the consultants at the University of Southampton, and he's going to talk to us about identifying and overcoming systemic barriers to care for patients with liver disease. We'll have a talk and then we'll have some questions and answers at the end. If you do have any questions, please put them in the question and answer box and we'll go through them all at the end. So thank you very much, and thank you, Ryan.
Thanks very much, Louisa. Hopefully you can see those slides okay.
Yes, perfect.
Yeah, fantastic. So yeah, thanks for the introduction and thanks very much for the opportunity to present this evening. So as Louisa said, I'm Ryan Buchanan. I'm an associate professor and honorary consultant down in Southampton in hepatology. My main research interest is around inequalities in liver health, and that stems from the kind of area where I did my PhD really, which was focused on access to care for patients with hepatitis C, and specifically people who inject drugs. So I probably don't need to tell most of the audience this evening that liver health is characterized by deep inequality. And if anyone's in kind of any doubt about that, might be worth just thinking about the kind of people who we see in clinic compared to the kind of patients that we look after as hospital inpatients, and sadly often die of liver disease. In my experience, certainly they are not the same individuals. They have different socio-economic backgrounds. People in hospital often don't speak English as their first language. And there is a different distribution of disease etiology, with hospital inpatients more frequently, in my experience, having alcohol-related liver disease. And these kind of observations are borne out in national data. So this graph is available online via the fingertips data, and you can just search for this liver disease profiles on Google, and it gives you a whole sort of host of graphs and data around inequalities in liver health. But this is particularly striking. So what this graph shows is coloured lines that represent deciles of deprivation, measured here as a composite score of index of multiple deprivation, and the number per 100,000 per year of people admitted with liver disease per deciles, with the colours corresponding to the deciles. And as you can see, for each decile increase in index multiple deprivation, your risk of being admitted with liver disease goes up. And that is particularly noticeable when you look specifically at alcohol-related liver disease, with those in the most deprived decile being almost 5 times more likely to be admitted per member of the population with liver disease. Index of multiple deprivation is an interesting way of looking at our population. It definitely gives us some insights into the distribution of liver disease according to socio-demographic and socio-economic factors. It is a composite score that incorporates things like income, your employment status, your education, your health and disability status, crime, housing, and your living environment. And this is a map of Southampton divided by lower layer super output area, which is basically like the first 5 digits of your postcode, and can include sort of 400 to 1,400 households. But it gives you a kind of representation, particularly if you look at it on a city level, of where are the pockets of deprivation and where are the pockets of relative affluence. And we're going to come back to index multiple deprivation later. It's sometimes, I think, tempting to think that the distribution of harm from alcohol, when you look at it divided by index multiple deprivation, is simply a reflection of asymmetrical distribution of risk factors. But actually, the picture is much more complex than that. And an example of this is the alcohol harm paradox. So the alcohol harm paradox refers to the observation that individuals in lower socioeconomic groups experience higher rates of alcohol-related harm compared to those in higher socioeconomic groups, despite reporting similar or even lower levels of alcohol consumption. So hypotheses as to why this may be the case, including co-occurring health challenges. And we know that the kind of coexistence of multiple risk factors for liver disease can be multiplicative. Patterns of consumption of alcohol is another thought. Environmental and social stresses, and then of relevance to today's talk is access to healthcare. Before I go any further, I'm just going to introduce, I thought I'd kind of make this a little bit real world by introducing a case. So this case is a kind of a composite of a number of patients I've met over the years, and in no way is kind of identifiable to a particular individual, and any images that have been used are kind of stock images. But I think it illustrates some of the points we're making quite well. So meet Leanne. So in 2016, she was 32, and she underwent an ultrasound scan because of abdominal discomfort. The ultrasound scan showed some cirrhosis and portal hypertension. And that was reviewed by a surgical team who referred her on to the hepatology team. The hepatology team in 2016 never actually met her, and there was a record of her having DNA'd 2 appointments, and then in keeping with departmental policy, she was discharged from the service. Unfortunately, 4 years later, in 2020, she was admitted with abdominal distension and jaundice, and she was treated with alcohol-related hepatitis. She had a slow recovery afterwards, which involved multiple episodes of large volume paracentesis. She did, however, during this time move into more stable accommodation and reconnected with her adopted family. In 2021, she was seen in clinic actually with a family member and had been abstinent for 10 months at that time. She was thin, her weight was only 56 kilograms, and it was noted that she had psychiatric comorbidities with bipolar disorder in the background and depression, and she remained slightly jaundiced. Late 2021, her bloods still hadn't resolved, so she was considered for a TIPSOR transplant because of the ongoing need for occasional large volume paracentesis. Fairly soon after, she underwent a transplant assessment, but it was felt that actually the bloods were slowly improving with abstinence, so the decision was made to wait. In 2023, she'd been abstinent for 2 years, but her UCAL had stuck and was no longer improving. She ended up getting 2 opinions for liver transplant, and both corroborated each other and declined listing. And the reasons given were high risk of relapse, missed hospital appointments back in 2016, and there was a record of her having self-discharged from a hospital on 1 occasion. From 2024 onwards, she is obviously older. She's being managed in a palliative pathway, but since that period where she really engaged with care around the time she was trying to get better after the admission with alcohol-related hepatitis and going through the transplant assessment process, she's really disengaged from care. She's probably returned to low-level drinking, and there's probably drugs. She's also vulnerable. Safeguardings have been raised. There's a thought that her sort of living accommodation may be being cuckooed. She's having occasional large volume paracentesis when she engages with care, and she remains very malnourished. Now, I'm certainly not suggesting in any way that the transplant decisions that were made about Leanne were incorrect, but it was really striking for me to see how much of an impact her missing those appointments early in her care pathway had on her long-term outlook from liver disease. And so what did Leanne miss out on in terms of liver care during the course of her illness by not being able to engage with the services that were open to her? So, I mean, basically, this is a slide that says, what do we do as hepatologists? So we offer access to diagnostic services, often through community engagement with community stakeholders in the first instance, whether that's non-invasive tests for liver fibrosis via venipuncture like the ELF test or FIB4 or FibroScan. These can be opportunities to impart behaviour change advice by experts. We, at least at the moment, through the treatment of chronic viral hepatitis, are able to stop or reverse inflammation and fibrosis. And in the not too distant future, one suspects we're going to get access to medications that would be able to do that in patients with MASLD and perhaps MET ALD. We can engage patients with liver cancer surveillance. If a cancer is detected, we can engage patients with curative treatment for liver cancer. To prevent variceal hemorrhage, we can undertake procedures or start medicines as primary prophylaxis, and we can start medicines and again impart behaviour change advice to reduce the risk that patients suffer from decompensation. And if all that goes wrong for selected patients, there is an opportunity to undergo a liver transplant. Sadly for Leanne, everything really was against her. She actually had been abandoned as a child and had been involved with an adopted family, but had remained very vulnerable. Her social network was probably harmful rather than supportive. She had housing instability, she had food insecurity, she had income instability. Those around her and herself were involved in health harming behaviours in the run up to her becoming very unwell with liver disease. And as part of all of that, wrapped up in all of that, she had poor access to the healthcare services that were on offer. And if you look at this from a population level, this creates a social epidemiological gap. So people like Leanne present with instant disease earlier. She was 32. They are diagnosed relatively late because of being unable to access diagnostic services. And they are more likely to suffer from complications of liver disease earlier. And that leads to an increased rate of hospital admission, which we saw on the opening slides, and increases their mortality relative to the rest of the population. Equality and equity, and I'll come on to equity in a minute, is being taken very seriously by NHS England. The 2019 NHS long-term plan had equality as one of its core aims. Specifically, the plan aimed to reduce health inequalities in England by addressing social, economic, and structural factors that affect health outcomes. It emphasises the need for targeted interventions for populations and communities that face the greatest disparities, including those in deprived areas, ethnic minorities, and people with disabilities. Key actions include improving access to healthcare services, particularly for underserved groups, and through community-based initiatives and outreach programs. I'm proud to say that I think the hepatology community has a very good example of achieving those aims in one specific area from the NHS long-term plan. But just before I go further, I'm just going to talk briefly about equity. I'm lucky enough to work very closely with public health experts, and they've kind of taught me the difference. And actually, in a lot of what we do, we are striving not to address inequality, but to achieve health equity, and the difference is subtle. But this diagram on this page kind of tries to illustrate the difference between the two, and I've put some text on the right-hand side to kind of give an example. So if we assume that an apple here is a healthcare interaction, where you have inequality, you might have a liver clinic that's in a hospital that's just been built next to a motorway with no other transport options. And of course, some patients don't drive and so have no chance of getting to that hospital service. To achieve equality, the hospital managers equality of access, the hospital managers might set up a new bus service to help patients access the site, but the bus is expensive. So to achieve equity of access, they may therefore have to subsidise bus fares for people on low incomes to reach the liver clinic. And from the picture here, what they're effectively having to do is to achieve equity, they have to give some patients a longer ladder or a leg up. And that is what I'm going to come on to now when it came to hepatitis C. So many of you on this call probably remember back to 2013 and what a busy liver clinic would look like then. The key difference between then and now is the fact there were paper notes, but also the pile of DNAs at the end of the clinic weren't patients with alcohol-related liver disease as they are now, at least in my experience. It was full of patients with hepatitis C from a particular social demographic, namely people who were either currently or relatively recently injecting drugs. And the letter at the time, a DNA letter, hopefully it wouldn't have been written quite like this, but might have read something like, unfortunately, Andrew couldn't find the time to attend specialist hepatology this afternoon. I'll leave it in your hands to inquire whether he'd like to attend in future. Now, of course, the reality is that Andrew would quite likely be somebody who was rough sleeping. Therefore, with no address to receive the appointment letter, no glasses to read the appointment letter should it have arrived, or perhaps a complete lack of literacy to enable him to read it, even if he had the glasses he needed. Or alternatively, he might have been in his late 70s and living on the south end of the Isle of Wight, when at this time, the only hepatitis C treatment service was in Southampton, which required 2 buses, a ferry, 3 buses, and a very expensive ferry. In both settings, there was absolutely no chance that patient was going to engage with that care pathway. And that's before you get on to the fact that in order to achieve a cure from hepatitis C back in 2013, you had to go through up to 7 steps, many of which involved regular hospital admissions, and for many also included liver biopsy. But 4 things happened, 4 good things happened that have helped achieve equity in the delivery of hepatitis C care. We achieved new drugs. Now, whilst they were expensive, they were much more accessible to patients because, in particular, they didn't have a contraindication of psychiatric comorbidity, which counted a lot of patients out from the old treatments. We got a new perspective, and that new perspective was achieved by embedding patients or people with a lived experience of hepatitis C and substance misuse in the development of the care pathway for hepatitis C. With this came more money, and from initially the WHO and later NHS England, there was a clear mission statement to achieve the elimination of hepatitis C by 2030. And as such, the care pathway for hepatitis C was transformed. From 7 steps, it became 2 steps, and most of those steps were focused in a community setting with very little need for hospital interaction. And as such, we are on track to achieve hepatitis C elimination 5 years ahead of the global targets. But whilst hepatitis C is good news, sadly, the general trend in liver disease is not a positive picture. There has been a steady increase since 2002 in deaths in males and females aged under 17 from liver disease, with a notable uptick in that since 2020 and the COVID pandemic. So we clearly need to do more to address this. And I think to do this, we need to look specifically at some very important outstanding questions that, in my view, to date have been somewhat neglected and the answers assumed rather than investigated. So question number 1 would be, what is the scale and the cost of non-engagement with liver care? This is undoubtedly high, but from my literature searching, appears to be completely unquantified. It could be relatively easily established by doing a cross-sectional observational service evaluation with an embedded cost analysis. And just on the back of that cost and the potential cost saving of redesigning care, it would be possible to advocate for service redesign. Question 2, who does not engage effectively with care? Surprisingly, the people who don't turn up to clinic are, in the literature at least, very poorly characterized. I've already imparted some of my own sort of anecdotal assumptions about who they are, but there isn't much written about it. And as such, it's quite hard to advocate for specific interventions to address this problem. The way to do this again would be using cross-sectional observational data and or just a simple service evaluation. Looking through the internet, it is possible to find the odd paper that has tried to characterize these individuals. However, there's nothing that I could see from the UK that have looked specifically at this problem. This is probably the most relevant paper, which has come from a group in the Midwest of the United States that have specifically focused on describing and defining the patients who do not attend liver healthcare clinics. And if you look at the table that I've highlighted here, a lot of it is not particularly striking or unexpected. So patients with hepatitis C have an odds ratio of 4 of not attending clinics. If you've got hepatitis C, you're more likely to not attend. If you've got alcohol-related liver disease, you're more likely to not attend. If you've got a longer gap between referral and the appointment, you've got you're more likely to not attend. And if you're of a black versus a white race, you're more likely to not attend. Interestingly, in this paper, something here, the Social Vulnerability Index, which is basically CDC's version of Index of Multiple Deprivation in the States, is not associated with your likelihood of attending an appointment or not. We have one of our public health master students in Southampton. We have tried to have a look at this in a slightly different way. So Hannah McCarthy looked at the meta-analysis that was published on HCC surveillance by Singhal et al. In 2021, which I'll highlight again in a minute. But rather than asking the question that they asked, which was, is HCC surveillance associated with good stuff happening to patients? She looked at the same papers but asked who isn't in HCC surveillance and what are their defining characteristics. And what she was able to pull out of that data was that men and smokers and people with background MASLD and hepatitis B were less likely to have an HCC diagnosed as part of surveillance. There's a couple of caveats to that. So first of all, those papers didn't differentiate between whether the patient had been diagnosed and referred but not attending, or was just had undiagnosed background liver disease. Whereas the focus of this talk is more on people who've perhaps had liver disease identified but are not engaging with the care that they're eligible for. And the other problem with this is these studies, and this maps to most cohort studies, are have very limited socio-demographic data about patients. So we get smoking, their sex, their etiology of liver disease. There isn't index of multiple deprivation or kind of international variants of that in these papers. So it's very hard to really dig into and define who these people are from this kind of published cohort data. Question 3, is poor engagement with care in and of itself associated with major adverse liver outcomes? So that's HCC, the development of cirrhosis, decompensation, bleeding, etc. This is also poorly quantified. The study that would be needed to quantify it would be ideally a prospective cohort study that measures engagement as an exposure, and then looks at bad liver stuff happening as an outcome. So the study would look something like this. So you'd have your exposed individuals would be people who had some measure of non-attendance, whereas unexposed individuals in your cohort would be attending well. And then over time, you'd follow them up, and then you'd be looking at the rates of incident disease between those two groups. And my hypothesis going into this would my positive hypothesis would be that those who are not attending care would do less well. Again, it sounds obvious, but it's quite difficult to advocate for service redesign and investment without these kind of numbers. And I've had a meeting in the last few weeks about setting up a kind of satellite or a virtual clinic for patients who we know struggle to engage with the liver care pathway, to really invest in their care and support them to engage wherever we can. And the first thing the deputy medical director asked me was, do we know they do worse if they don't turn up? And I can say yes to an extent, but we don't have much of this kind of data to lean on, particularly in England. And then but there is some evidence. So this is the meta-analysis that was looking at HCCs diagnosed as part of surveillance versus not diagnosed as part of surveillance, that was published by Singhal et al. In Journal of Hepatology in 2022. And it showed that if you have an HCC diagnosed as part of surveillance, it's likely to be smaller, you're more likely to receive curative treatment, and you're less likely to die. And so on the face of it, that seems to suggest that engaging with care is associated with better outcomes for liver disease, but it is subject to the caveats that I talked about earlier that Hannah uncovered when she was doing that secondary analysis on the same data. And then we move on to an outstanding qualitative question. So if we've identified what's the scale of the problem, who does it involve? A sensible thing to do next would be to ask those individuals, why are you struggling to engage effectively with healthcare services? And in this area, there is some supporting data. And I recently was fortunate enough to collaborate with other collaborations around the country who'd been funded as part of an NIHR program starting to dig into this, including Ashwin Danda down in Plymouth and a team up in Teesside, and Ahmed Al-Shakawi in Birmingham. And we kind of put together our findings from, I guess, a national conversation really with patients and patient advocates that tried to dig into why patients at risk of or with liver disease might struggle to engage with care. And two things came through really, really strongly: stigma and self-stigmatization, and mistrust of healthcare professionals aligned with fear. And in the background were all these social determinants of health that we pulled out. So unstable housing, language barriers, job security, poor health literacy, being from a marginalized minority, the environment you're living in, your economic status, education, food insecurity, and so on. And all of these things contribute to this health inequity. And there is a reasonable amount published alongside this, looking at barriers to care for patients with liver disease. And because this is a why question, these studies are usually qualitative in nature, so they involve research interviews or focus groups, perhaps sometimes feedback as part of a service evaluation, or, as I've just described, patient and public involvement workshops. This is an example of a paper published by a group working out of King's, and they identified a number of themes that kind of underpinned why patients with comorbid alcohol use disorder struggle to engage with care. And of relevance to this talk, one of the themes was kind of systemic factors. I've just pulled out two of the quotes here. So one was around miscommunication. So it's just the miscommunication. Before they sent you a message saying you've got an appointment, then that stopped. And then you get a letter saying you missed an appointment. And that's, when you think that missed appointments can mean you don't get a liver transplant, that suddenly takes on a whole new level of importance. Or then the next quote was all about kind of health literacy and being aware of the pathway and that you were being treated in. So it would help me to know more about what's going to happen, how it's going to happen, being involved in the system, knowing more. And that also kind of nods back to that, the importance of engaging patients in the development of these care pathways. So if you know the scale of the problem, who's affected, and some idea about the mechanism that's causing the problem or the barrier, then you can start to design and then test interventions to enhance engagement with liver care services. And these would be interventional studies. I mean, they could be practical pilot services, as is going on at the moment with NHS England and liver cancer. They could be natural experiments that sort of take advantage of kind of naturally occurring service innovations to compare new services, or kind of more conventional clinical trials. And the kind of things, the kind of areas of intervention that we pulled out from the kind of combined work, the collaborations, include those that focus on health literacy, those that focus on peer support, those that focus on integrating services, and those that focus on reducing stigma through healthcare professional training. And I was looking for a really good example of where research and an interventional study has kind of tested a change in the kind of system. And I think, in my view, best example does come from the hepatitis C world. So this was Andrew Radley and John Dillon up in Dundee, who some of you will undoubtedly be aware of their work in hepatitis C. But back in 2022, I think, or 2020, they published a cluster randomized control trial where they had basically trialed a completely new healthcare service system for hepatitis C. So they randomized whole pharmacies, 28 pharmacies went into each group, with some pharmacies managing their patients on opiate substitution therapy via the normal, via usual care, and the other group randomizing managing patients through pharmacist-led care. So that included everything from doing the testing, telling them the result, starting them on treatment, following them up through treatment, and then checking that they had cleared the virus 12 weeks after treatment. And as you can see by the kind of bottom squares on this diagram here, you had almost double the completed treatment rate in the patients that were managed through the pharmacist-led care pathway. So I guess, we haven't done this kind of systemic change, at least not that I'm aware of, outside of hepatitis C. But given the rising incidence of death from liver disease, it's clearly still needed. So just coming on now to a couple of summary slides. So I think to move forward, there are 4 things we need to do. We need to look for and record potential predictors of non-attendance and poor engagement. And what I mean by that from a kind of academic perspective is treat non-attendance as an outcome of interest and prospectively record social determinants as exposures. Because one of the problems we've got with using routine data and retrospective studies to do this kind of work is we are really bad at recording social determinants. Index of multiple deprivation can be pulled off from postcodes, but there are a couple of big problems with that. Number one, it's often not representative of where the person was at the time they were first diagnosed, because they might have moved. And number two, IMD maps to up to 1,200 households. So how much does that really tell you about that individual's education level, for example? The second thing we need to do is look more closely at how or if non-attendance impacts on major adverse liver outcomes. So in that case, the Marlows would be the outcome and non-attendance would be an exposure. Thirdly, ask why. And when asking why, be aware of the things we think we already know. So stigma, geographical inequality, literacy, housing, but ask it in a qualitative way that means we remain open to understanding the things that we don't already know. And number 4, I think we have a huge amount that we can learn from the hepatitis C elimination program. And we should use that to redesign services with patient representation and, importantly, representative patients. So not kind of professional PPI or retired scientists who want to kind of contribute to research. We need a representation of the real people that we're looking after at the core of this. And if I may, I'm just going to conclude with an opinion. So I think DNAs really matter. I mean, they matter for one reason, because it means that the clinics run on time, but they also really matter because they are the patients that are most likely to end up in hospital and die from liver disease. And paradoxically, some of the services we operate are actually least accessible to the patients with the greatest risk of liver-related mortality. And then I've just chunked out the last bit of that figure that I displayed on the earlier slide. So we looked at inequality, we looked at equity, and then this is justice. So if we use that similar example of the kind of car parking and then the subsidized bus, justice would be if the liver clinic was actually built in the city centre so that some people can walk, some people can drive, some people can get the bus. And so nobody even needs a longer ladder to access the care that they need. And with that, I'm going to stop. Over to you, Louisa.
Great. Thank you so much, Ryan, for a fantastic talk. We're going to start with some of the questions, if that's okay. So the first question coming from Christopher Oldroyd is asking, could you be more specific about how you might define engagement or attendance? Does one DNA make you a non-attender, or two DNAs? What if they didn't turn up but answered the phone? This would be quite important for conducting retrospective or prospective studies on outcomes and identifying your target population for an intervention.
That is a brilliant question. So going back to those four things, so where you have attendance or engaged, not engaged as an exposure in your cohort studies and bad stuff happening as your outcome, you have to be really consistent and kind of watertight on who you're talking and what the exposure is. And it's difficult because, you know, it's a continuous variable attendance, isn't it? It's sort of a proportion of appointments attended would be kind of one way of looking at it. So it's very hard to categorize people into two groups in the way you normally would. So how have people got around this? So some of the HCC surveillance literature, those studies that were included in that meta-analysis, some treat it as binary. So they kind of had a cutoff. If they attended less than half their appointments, that was it. They were a non-attender. Or a proportion, maybe half of those studies actually had three categories. So they had some attendance, no attendance, excellent attendance, and there was kind of defined cutoffs that mapped to that. From a sort of slightly more pragmatic answer, we've recently set up a program where we enroll people with peer support to attend HCC surveillance and other aspects of liver care. And the kind of entry criteria we've left deliberately vague. So it's actually a clinical decision. So if you, as the practitioner, think this person is going to struggle to attend their next appointment, you refer them to the program. And actually, I think we're quite good at spotting people who are going to struggle to turn up. So I think if you're embedding this into outside of research, if you're kind of embedding this into an intervention, I think leaning on the expertise and pragmatism of the clinicians to make the judgment call is a good thing to do too.
Great, thanks, Ryan. So we've got another question for you from Callum Wood. So he says, since 2020, about 90% of my outpatient consultations are by telephone. And and he wants to know, do you think this has helped in engagement at all? And then a follow-up from that, even when patients DNA, do you do anything beyond just writing the standard DNA letter?
So telephone. Personally, I hate it. I sort of trained to see people face to face. I think for the kind of population that we've just been talking about, I don't think it helps. I think there are definitely groups of patients where it helps tremendously. But I don't think it helps with marginalized and underserved patients. And I also think, particularly for that group, what is needed for a benefit to be conveyed by the clinical interaction is trust. And if they don't meet you and you're just a voice on the telephone, I don't think they trust you. So no, to answer that.
And the bit of, and what do you do for your DNAs? Do you do
Oh
anything
yes.
beyond just a standard letter, or?
So because so in Bournemouth, Southampton, and now Portsmouth, we have a peer engagement program for patients that we think are going to struggle to engage, who need to have compensated or decompensated liver disease and need to be kind of needing to go to variceal banding or HCC surveillance. Or for those patients, if you're in clinic and they haven't turned up and you look back and it's kind of littered with DNA letters, our plan is now sadly needs HCC surveillance such and such. I have referred to our enhanced care pathway, who will pick up our onward follow-up and copy that letter to our nurse that coordinates that pathway, and he adds them to the kind of enhanced care spreadsheet and does what he can. And that may involving a peer to support them. But so it's quite empowering, because I used to feel a little bit of shame inside when you're just like, tough luck, you're gone. When you just don't know what circumstances that person's in, or if it's your mess up because the admin system's fallen apart.
Thank you. We have a question from Ashwin Danda, who says, completely agree that we need to tackle engagement with liver services to improve patient outcomes and deliver a cost-effective service. Do we know what the best model of care is? Is it community-based, integrated, multi-professional, or virtual?
I'm sure Ashwin probably has a good idea himself, but I guess a combination would be best, and I think in some respects we're getting close to that. We now have kind of telephone, video, or face to face, and a legacy of COVID, I suppose, is that we have the kind of IT know-how and patient expectations are such that we can use any of those three modalities. Community-based, yeah, I think we're probably politically there's a move in that direction, and that's got to be good. Southampton, again, to use Southampton as an example, there is this big hospital out in the kind of northwest of the city that is a long way from most of our most vulnerable patients. The city centre hospital, as is the case in a lot of places, is sort of this semi-derelict site. And there is a move back towards that site, subject to some renovation, because it's kind of been realised that half our patients can't get to the other location. But that's been kind of 20 years in the making.
Great, thank you. And Ashwin also asked, what would you recommend we implement into our everyday practice to reduce non-attendance? So totally agree. He says our policy is far from optimal. 2 DNAs and you get a letter saying they're out, and they might only get a letter or text message reminder, which often comes after the appointment, doesn't it?
Yes. So there's some quick wins, isn't there? So I think health literacy, if you just think about HCC surveillance, we've been terrible over the previous decades about telling people why they need a 6-monthly ultrasound, and there's a lot of posters, particularly at the conferences now, that outline how bad people's understanding are and how bad we have been at imparting the knowledge as to why they need a 6-monthly ultrasound. And we've recently redesigned, with patient involvement, our kind of information sheets that go out to patients who are on the HCC surveillance program. That's a quick win, very cheap. And then at the kind of sharp end but more expensive end is the use of peers. That is a big takeaway from the hepatitis C program, was how powerful that can be for a relatively small number of patients. But I think if you case select enough, and the sort of slightly generic case I presented this evening, I think if she'd been engaged with a peer program from the outset, things could have gone slightly differently for her. And so that's at the more expensive end of the spectrum, but we probably need to do a bit of everything.
Great, thanks.
Thank you. There's a question from Anne Archer who says, thank you for a great talk. Do you think the potential rationalisation of surveillance in future, for example, by the AMAP score, would have a positive or negative impact on engagement?
So I think it would, if in a healthcare economy with limited resources and the relatively high expense of things like peers, having a smaller number of patients to focus on for whichever intervention we're trying to get them in for is only likely to help. So yes, if there was rationalization through non-invasive scores, particularly for HCC surveillance, that could be helpful.
Great, thanks. And then we've got another question from Rachel. So Rachel says, thank you for a fantastic talk. And then she says, the hepatitis C experience has shown us the benefits of being able to access care through services present in most communities, say pharmacies, primary care, for example. And do you think this could be something that would be achievable for some aspects of hepatology care, say GPs with special interests, ADRS workers upskilling in areas of high need?
Yeah, so different settings. So I mean, certainly diagnostics are moving out of hospital already, aren't they? And that's got to be good. I mean, whether we're talking about, so with the hepatitis C model, as well as involving pharmacies and primary care, well, particularly pharmacies, also involve buses. And I think buses in many locations now have got fibre scanning capability and are going to marginalised and underserved groups. So that's kind of outsourcing the diagnostics, which would have previously been hospital centric. Pharmacies, so we've done some research in Southampton that's looked at the potential utility of pharmacies to identify people who are drinking at harmful levels, impart a brief intervention, and then engage with them with a diagnostic pathway for liver disease. Pharmacies and pharmacists certainly showed in hepatitis C how good a resource they can be. You know, they're highly trained professionals who are very good at dealing with marginalized populations because they do it day in, day out through methadone and other substance misuse services. So that may be something for the future. Primary care is always difficult because you just come up against the capacity problem because they are so stretched. To kind of divert them into a specialist interest seems to be, in my experience, getting actually more difficult. We work within the hepatitis C program. There are GP champions who are kind of embedded within the program, who are kind of one of their roles is empowering primary care to be more active in the hepatitis C space. That's quite expensive because you're paying for a GP's time, but it potentially is quite impactful because they access GP training, GP seminars at a kind of peer level. So that's something maybe to think about.
So do you think we should have an HCC surveillance bus then that goes around to the hard to reach patients maybe?
So ultrasound on the bus. Yeah, it's probably coming, isn't it, as part of the NHS England program. I think we'll probably eventually get there. And it's got to be, I mean, it's probably a good thing for hospital. You know, if you just think about the burden on hospital care, all of these ultrasounds, car parking, just as one example, that's got to be progress, I would think. And it's potentially, if you look at regionally, it's a way of ensuring equitable access as well, because I don't know about down in Plymouth, but in Wessex, we have kind of pockets of high resource and pockets of less resource, and mobile infrastructure can overcome that quite effectively, and that was evident in the hepatitis C arena.
Great, thanks. Tamar, do you want to do, there's one more question that's popped up.
Oh yes, thank you. So thank you. It's a question from Kate Drysdale, says, great talk, thanks. In some areas, the HCV elimination program used incentives such as vouchers, providing nutritional supplements to encourage engagement with testing, treatment, and SVR checks. Do you know if this sort of approach has merit for other populations, for example, people with alcohol-related liver disease? And there's a second part, and what would you do for IMD for people who are homeless who won't have a true postcode?
So on the IMD one first, so IMD's good, but it's not that good. For that is one reason. So if you're an FA, where do they put you? I think you're automatically put into decile 10, but I could be wrong. But what I do is look prospectively and use some validated measures that map to social determinants of health. We've been looking recently at one that's specifically designed to assess food insecurity, and that is actually probably a really important socio-demographic factor that maps to outcomes, particularly in patients with MASLD, and yet has never been deployed in a UK cohort. So I guess use IMD, but be aware of its limitations and get away from it. And then on the incentives and vouchers, so in the Hep C program and Hep C research as well, incentives, financial incentive, actual monetary incentives, as well as kind of food vouchers and things, have been effective. And a lot of the people who are deeply embedded in the program will tell you how important they are at getting engagement. We ran a study called the SHIELD study, which was a feasibility study looking at a network-based intervention where people from unstable housing backgrounds, so from hostels and things, were incentivized with vouchers to bring their drinking partners to FibroScan assessment. And it didn't work anything like as well as the similar network-based interventions we'd used in people who inject drugs. And there's a couple of reasons for that. Number one, kind of recruiting to the alcohol-related liver disease study was actually far more effective through kind of gatekeepers who ran the kind of wet houses, the kind of hostel workers who were trusted. And actually that was really effective. So we kind of didn't need this kind of peer incentive program. And the second thing was people who inject drugs are just overwhelmingly motivated by money, because of the servicing of their addiction. And so it is a very kind of powerful intervention to give them something that can be converted to cash. And I think that's kind of well recognized. So I think probably no, I don't think it's going to have the same level of impact as it did in the Hep C program.
Great, thanks. Ryan, I wondered if I could just ask a question. Can you tell us a little bit more? You talked about the peers and the support that they offer. Can you tell us a little bit more about that and the service you have with that in Southampton? You know, how many do you have? How many patients can they support? Does it cost anything?
Yes. So so this is something called the Helixa program. So the NHS England pilots that have been going for a couple of years now, that kind of supercharged fibre scanning in community settings. We in Wessex, we use that money instead to supercharge engagement with HCC surveillance for the patients that we already knew had cirrhosis but weren't coming. Because we had, like most people, most centres, I think kind of 50% of our cirrhotic cohort were kind of out there somewhere. And so off using that money from NHS England, we employed 3 peers. We've employed them now for 2 years, who are people with kind of a lived experience of substance misuse and alcohol, including alcohol and drugs, who are line managed through the Hepatitis C Trust, who have a lot of experience working with peers. They can all drive, and they are referred to patients who need cirrhosis, who, as I said earlier, have kind of been pragmatically decided to be falling outside of care. And they get them in for their appointments, basically. They have, the program in total has worked with 600 people, I think, to date. The peers have been involved with about 200 of those. The other 400 either couldn't be contacted or didn't need peer support. And they've got an overwhelming majority of those people consistently into HCC surveillance over 2 years. And they have now picked up, I think, 6 HCCs as a result of that supported attendance. So yeah, so that's how we've done it. They're paid, and it's kind of band 4, band 5 NHS kind of salary level, so it's not cheap. And so it's an expensive resource targeted at relatively few patients. But as far as I'm aware, the rest of the NHS England programme, the whole national programme, has picked up 11 HCCs from all the fibre scanning that's been done around the country. Our peers have picked up 5 just in Wessex, and that's because they are working with an extremely high-risk population for complications of liver cirrhosis.
Great. We've got one question that's just popped up about this. So saying, from Hazel Woodland, so is the funding for the peer support secured long term?
No. I'm working on a year-by-year basis, and currently in the midst of that at the minute. So no, sorry, Hazel. It's not.
Okay, but it sounds like a very successful programme. So, perfect. So we don't seem to have any more questions in the chat, and we're coming towards the end of our hour. So I'd just like to thank my co-chair, Tamar, and thank you very much. Obviously, Ryan, we really appreciate your time and your talk. It was really great and fascinating. And thanks again to our sponsors. And we hope we'll see you all soon at our next School of Hepatology webinar.